All right. Next video in the video series, getting straight into the uh, best first randomized clinical trials. So why are randomized clinical trials so great? I think every medical student at this point in their education will know that what's the best kind of biomedical research? It's the RCTs. But why are they so good? So this darling is falling out of favor, tranexamic acid. Um, but here's a recent study. Just take a moment. Uh, so let's talk a bit about selection bias. Most frequent bias encountered in clinical research. Basically, are we enrolling a representative population, but also who, uh, if you're not randomizing, who would get TXA in this study if it wasn't randomized and who wouldn't? There's a strong possibility that there would either be the candidates that it's easier to give TXA in, or conversely, the candidates that are sicker would be more likely to get TXA. So it would be we would be unable to tell if there's a systematic bias that makes it either healthier patients get TXA or more ill patients get TXA. So most selection bias is patient driven. Um, this example is a classic one always given. You can't study the effects of vitamins on health outcomes because patients who take vitamins are more likely to take many other steps for their health. So by randomizing patients to treatment versus control, neither patient nor physician bias will affect the group assignment. Uh, the only other way to reduce it is to figure out what likely confounders are present and control for them, but only confounders that you know of and can legitimately control for can you actually uh, get away by statistical chicanery. Otherwise, they're very frequently unknown factors that are affecting outcome, and you can't control for them if you don't know about them. So here's a randomized clinical trial, and immediately you can see by the numbers that something's up. The randomization kind of failed because somehow stress education got half the participants that the others did. And this can actually sometimes happen with legitimate randomization, which is why there are many ways to randomize things. And you have to know when you're developing a study or when you're assessing a study that you're reading, which is the best way. So the common methods of randomization are simple, block, stratified, and unequal. So simple randomization is the thing that everybody thinks of when they randomize, just coin flip, dice roll, whatever. Each patient individual has a random chance individually to be assigned to treatment or control. But some things can happen when you get small sample sizes, and the previous sample size wasn't all that small, but it probably somehow it happened that there was cohorting like that. So here you can see these are a totally random creation of group B and A, and somehow group A has 3 patients in it and group B has 7. So that's more than twice the amount, and all it requires is 2 random flips from B to A, and suddenly, voila, something that would originally have been equal is now very unequal. A block randomization is usually used in these settings. So you take a block size of 4, and the first 4 patients that come in are assigned to a block, and the blocks can go 6 different ways, and basically they're the first patient of a group of 4 that comes in gets randomly assigned to one of these blocks, either AABB, BBAA, etc. and then the next 3 patients fall in line. Whoops. And then basically it assures that you have equal numbers in each group for every 4 patients. The thing you have to do is you can't reveal the block size to the data collectors because it might unveil blinding. You can know, you have an increased guess basically at who is placebo and who is control when you're collecting data, and especially if the outcome is subjective, it might the data collectors and the outcome assessors might be able to encourage results in one direction or another. And the block size needs to be at least twice the number of available groups. So here's an example of block randomization. So sometimes if you have small numbers with the block and there are significant confounders, then you can somehow get the same problem with simple randomization, only that confounding variables creep in to the block. So here you go. Somehow group A had much more smokers than group B, and that could cause problems with your data. And it's sometimes, if your group size is so small, you'll just have to sometimes deal with it. And here is stratified random block sampling. This is stratified random block sampling is a way of potentially dealing with significant confounders. And you basically, it's blocks nested within blocks of, of significant confounders that you assess a priori. But there's kind of a weird point that if your sample study is too small, you're going to lose statistical power. But if your sample size is going to be very large, it's very likely not going to be an issue. So it's kind of those mid-range samples that you want to do it in. Sometimes, you don't do the one-to-one randomization, even though it'll make statistics easier. Sometimes you can do, just like with case control studies, which we'll get into in a little bit, you can do unequal randomization, and greater than 3-to-1 unequal randomization is not recommended due to loss of statistical power. Here's an example of that. Basically, because social work and counseling and individualized outpatient are such high intensity, high resource utilizing services, that they didn't want to do a one-to-one because they wouldn't have had a large enough sample size, and also they would have just had to do too many of those. They didn't have the resources at the time that the study was done to counsel everybody like that they would have had to in a one-to-one assessment. So they're so great. Why aren't all studies randomized? So randomization is the one factor of clinical research that actually can impact the treatment that patients receive, and especially if you are exposing patients to like a novel therapeutic, whoopsie, you can actually cause harm with it if you're not aware. Sometimes that's how science happens. I don't want to compare patients to eggs made in an omelet, but that's sad to say, that's one of the risks. And this is part of the informed consent process, that when you randomize patients, you tell them, hey, we don't know everything about this drug. If you're not cool with that, you don't have to participate in this study. So that's why informed consent is such a big deal. All right. The The other issue is you can't randomize people to stuff that you know is dangerous. Smoking or driving without a seatbelt are chief examples. There is, few people know this, but there is no randomized control trial that tells us smoking causes cancer. We were able to figure out that smoking causes cancer by the preponderance of weaker evidence because you can't randomize someone to a 30-pack year smoking history. It's just simply, logistically impossible unless you imprison them. And we're not going to do that. So, do you, in a randomized control studies, do you use control? What do you use for control? A placebo or other? Placebo trials are very rarely used in medical science these days because it's considered unethical to withhold therapy from patients. So it's typically what's typically done is standard of care versus new care, and also clinicians don't really care about, is this new shiny thing better than doing nothing at all? They want to know, is this new shiny thing better than doing what we have been doing up until this point? Placebo is really only acceptable if there's no standard therapeutic option. And that's pretty much it. This is kind of a nitpicky point, but sometimes if you just because something says random doesn't mean it's random. Excel has an ability to make random numbers, but they're actually pseudo-random numbers. There's actually underlying code. And whenever there's underlying code that makes the random number, it can actually there can be hidden patterns that appear in there. And a good resource that I use a lot is random.org will generate truly random numbers based on radio noise. How to blind. So blinding can only happen if patients are randomized, and should always be performed if outcome measures are subjective. And you don't technically need to do it if outcome measured are objective, but sometimes it looks better, and sometimes it is infeasible to blind. There's you need staff to make blind medications. You need to make it look like you need to make the medications look like each other, and sometimes that's just not possible. Sham procedures are frequently done for surgery randomization, but that has its own ethical concern in terms of we're cutting into you, but we're not actually, messing around with your plumbing. Now patients are exposed to the risk of a skin infection when in fact nothing happened to them. Now, if patients consent to that, that's great, but that has its own ethical concerns. If feasible, blinding should be performed. And if it is not performed, the paper needs to detail, this is why we didn't blind. And remember, no amount of randomization will protect your research if your population is not representative. You can't do a study inside of the Indian Health Services and expect it to apply to the rest of the United States population. That study can only be used to help patients of the Indian Health Services. All right. Any questions? Feel free to email me if you're taking the course. You can always leave questions in the comments if you're not. Thanks for playing.